Good morning, everyone. My case is a 66-year-old gentleman, resident of Alwar. He presented with chief complaints of yellowish discoloration of eyes, and high-colored urine since 15 days, pruritus since 10 days. Coming to history of presenting illness, patient noticed yellowish discoloration of eyes and high-colored urine since 15 days, insidious in onset, progressive in nature. There are no episodes of waxing or waning. It is not associated with pain abdomen or not preceded by any prodromal symptoms. It is associated with clay-colored stool. Patient also complains of pruritus since 10 days, generalized in nature, present throughout the day. It is disturbing his sleep and lifestyle. There is also a history of loss of appetite and loss of weight, which is not quantifiable. And there is no history of previous pain abdomen, jaundice, or fever. There is no history of hematemesis, melena, or vomiting. There is no history of abdominal distension, chest pain, or dyspnea. No history of back pain, headache, seizures, or blackouts. Coming to past history, patient is a known case of type 2 diabetes mellitus since 5 years on oral hypoglycemic agents. There is no worsening of sugar control or increase in the dosage of oral hypoglycemics recently. Known case of coronary artery disease, underwent PTCA and stenting in 2019. Patient is not a known case of hypertension, tuberculosis, or asthma. Surgical history, patient has underwent laparoscopic hernioplasty for bilateral inguinal hernia 10 years back. Patient consumes vegetarian diet, sleep is disturbed since 10 days, bowel and bladder habits are regular. There is no history of alcohol consumption or tobacco intake. Family history is not contributory. Coming to summary, an elderly male, known diabetic and coronary artery disease status post PTCA stenting with short duration of painless progressive obstructive jaundice with intractable pruritus and history of loss of weight and loss of appetite. I want to make a diagnosis of malignant obstructive jaundice.
No, it's not necessary to say coming to history of present illness or coming to past history. You should just continue to present it as a continuous story.
Sure.
What do you mean by prodromal symptoms?
Prodromal symptoms are fever, myalgia, malaise, which is usually seen in viral hepatitis cases.
It would have been better to say no prodromal symptoms suggestive of viral hepatitis. Some examiners may accept that. Some may insist that no, you should mention the specific symptoms. It is always better to elaborate rather than use only the word prodromal symptoms. Okay.
Sure. Okay.
Next. Okay. Next. Go back. Sorry. Spelling of pruritus.
Sorry, sir. No.
Yes. Next.
Yes, sir.
Next. What do you mean by previous pain abdomen?
Previous pain abdomen tells history of any biliary colic. Previous history.
Biliary colic. It is very unlikely that a 66-year-old gentleman has never had pain abdomen. Very, very unlikely. So you should say no history suggestive of biliary colic or no biliary pain.
Okay, sir.
And similarly, headache. Again, it is very unlikely that a 64-year-old person will say that I have never had headache. It is a recent onset, persistent, severe headache.
Okay, sir.
You're talking of intracranial metastasis. That is the presentation. Okay.
Okay.
Next. Avoid using acronyms. Use the full term. So don't say PTCA. What is PTCA? Percutaneous.
Percutaneous.
What is PTCA? Percutaneous. T is what?
Transabdominal.
Is it done transabdominal?
Transluminal, sir.
Huh?
Transluminal.
No. What lumen? What is the approach used for PTCA? What is CA?
Coronary angiogram.
Yes,
Angiogram.
not angiogram, angioplasty. Did you have, if it is stenting, it is angioplasty. It could be angiography if it is diagnostic, but if it is therapeutic, it is angioplasty.
Yes, sir.
So it is transfemoral.
Transfemoral. Okay, sir.
But now they do radial also. So it's not necessary that in every case it is transfemoral.
It's transcutaneous.
Hmm?
It is not transcutaneous. It is
Transcutaneous, which includes everything. Yeah. So Dr. Ajay is correcting me. He says it is now termed transcutaneous because then it could be femoral, it could be radial.
No, sir, it is transluminal.
It is
correct. It is PTCA, but it is transluminal coronary angiogram.
okay. So you are correct. Manmohan says that it is transluminal. Sorry, I was wrong. Okay. Go to your diagnosis, summary and diagnosis. So in the summary, instead of saying short duration, it is better to say the exact duration.
Okay, sir.
Because short could be 1 week, short could be 2 months. It's better to say how many days.
Okay, sir. Sure.
Would you like to pinpoint the site of malignancy?
At this point, it is difficult to pinpoint, sir.
What are the possibilities?
Possibilities are periampullary carcinoma, hilar cholangiocarcinoma, carcinoma gallbladder, and carcinoma head of pancreas.
Yeah. So since this is painless progressive jaundice,
Yes.
you are right that the two common causes of painless progressive jaundice would be periampullary and hilar, or any cholangiocarcinoma for that matter, but hilar is the commonest. And in any case, the lower CVD cholangiocarcinoma is included in periampullary. Mid CVD is less common. And carcinoma gallbladder and carcinoma head of the pancreas in a significant number of cases. So about 50 to 60% of gallbladder cancers with jaundice, and about 60 to 75% of patients with carcinoma head of the pancreas will have pain. So
Yes.
if you have painless progressive jaundice, they come lower down in the list. If you have pain and progressive jaundice, then head pancreas and gallbladder come higher in the list. Go back to your negative history once more. Okay, you have mentioned about, so out of the two, hematemesis or melena, which is more important?
Melena is more important.
Melena is more important. So again, some examiners would insist, or if you want to score some extra points, you should mention, for an undergraduate, it is all right that he knows that GI bleed means hematemesis, melena, or hematochezia. But for you, more important, more common things should be mentioned first, and then the less important or less common ones. Okay, let's move on. Ajay, anything on the history?
Which I'm not, but
Yeah.
I was not.
Okay.
I just wait.
Yeah, carry on.
General physical examination, elderly male, averagely built and nourished, elderly male, averagely built and nourished, with a BMI of 22, ECOG status of 1, is conscious, cooperative, and well-oriented to time, place, and person, lying comfortably in bed, pulse rate of 84 beats per minute, blood pressure of 136 by 80 millimeter of mercury, respiratory rate of 18 cycles per minute, with a 99 to 100% saturation improved.
iPhone, please mute yourself. Yes, carry on.
On examination, icterus is present. Scratch marks are noted all over the body. There is no pallor, left supraclavicular lymphadenopathy or pedal edema. Patient looks well hydrated, and there are no other signs of liver failure present. Shall I continue with examinations?
Yes, please.
On inspection, abdomen is flat, umbilicus is central position and inverted. All quadrants move equally during respiration. 3 laparoscopic port scar marks are seen over supraumbilical and paraumbilical region, healed by primary intention. There is no mass, sinuses, engorged veins, pulsation, or peristalsis seen. Hernial sites appear normal. No renal angle fullness, external genitalia normal. On palpation,
Wait for a minute.
Krishna, you didn't mention any previous surgery in the previous history.
yes, sir. I had mentioned he has underwent laparoscopic hernioplasty, sir, 10 years back.
Yeah, okay. So it's that.
On inspection, Abdomen is flat, umbilicus in central position and inverted. All quadrants move equally during respiration. 3 laparoscopic port scar marks seen over supraumbilical and paraumbilical region healed by primary intention. No mass, sinuses, engorged veins, pulsation or peristalsis seen. Hernial orifices appear normal. No renal angle fullness. External genitalia is normal. On palpation, abdomen is soft. There is no local rise of temperature, non-tender. Gallbladder is palpable on deep inspiration. No other mass or organ palpable. Hernial orifices normal, external genitalia normal. On percussion, liver dullness starts at 5th intercostal space.
gallbladder से related थोड़ी question को यार
12 centimeter. Dull note over gallbladder is continuous with liver dullness. The rest of the abdomen is resonant to percus. On auscultation, normal bowel sounds are heard. Per rectal examination, sphincter tone normal, no mass felt. Mucosa normal, normal fecal staining present, no pale stools. Examination of respiratory system, cardiovascular and CNS is essentially normal. Coming to summary, an elderly male with ECOG status of 1, known diabetic and coronary artery disease, status post percutaneous transluminal coronary angioplasty and stenting with 15 days history of painless progressive obstructive jaundice with intractable pruritus and history of loss of weight and loss of appetite. On examination, a patient is icteric with scratch marks all over the body and palpable gallbladder.
Go to your palpation. You just said gallbladder is palpable, but you didn't describe anything else.
Okay, sir. It is palpable in the right hypochondrium of size 4 into 3 centimeter. Rounded, all borders except upper border is well made out. Surface appears smooth, firm in consistency, smooth with respiration, and there is side to side mobility also.
So what is your inference of this palpable gallbladder?
There is a obstruction, distal obstruction, which is causing the gallbladder to distend, and it is not a gallbladder mass. It is a palpable, distended normal gallbladder.
So you should say, I think it is a distended palpable gallbladder rather than a GB mass.
Yes. Okay.
Go to the rectal examination. What do you mean by no mass felt?
Blemish of nodules can be felt in
You are
perrectal.
looking for an extra rectal, isn't it? A rectovesical pouch mass.
Yes, sir. Mass. Yes.
You should be clear on that. Because obviously you are not looking for a rectal mass. You are looking for an extra rectal or extra luminal or a rectovesical mass or nodule.
Yes, sir.
And yes, you said normal fecal staining, no pale stool, but it is good to say that no melena, no evidence of melena.
Okay.
You should always say what you were looking for and did not find.
Okay.
So in the ward round also, post-op day 1 after cholecystectomy or liver surgery, if a drain has been placed, it is good to say that drain shows so much of serous fluid, no bile. So that means that I know that you were looking for bile and it is not there.
Okay, sir.
Yeah. Yes. Yeah, carry on. Yes.
I want to make a diagnosis of malignant obstructive jaundice, sir. My differential diagnosis will be periampullary carcinoma, carcinoma gallbladder, and carcinoma head of pancreas.
But you said this is a distended gallbladder, not a GB mass. So how do you say it is carcinoma gallbladder?
In cases of gallbladder neck carcinoma, the GB can be distended with palpable GB without any mass palpable.
And these are the patients who will probably have painless progressive jaundice.
Yes.
So usually these are small cancers which have very early on involved the common duct and cause jaundice. So This is one variant of carcinoma gallbladder which can present as painless progressive jaundice rather than fundus and body gallbladder cancer, which will have pain.
Yes.
Okay, what will you do?
Next, I want to do certain investigation to arrive to a diagnosis. Next, I'll order an ultrasound of the abdomen of this patient.
Let's see. You don't order, you ask for or you request an investigation.
Sorry.
Only place you order is a restaurant.
Sorry. Yes, sir.
Yes.
Ultrasound abdomen shows a liver normal in size, shape, and echo texture. The hepatic biliary vesicles dilated in both lobes. A well-defined hypoechoic lesion with irregular margin noted in GB fossa of size 24 into 27 mm, possibly of neoplastic etiology. Gallbladder wall thickness normal, lumen is echo-free. CBD dilated 12 mm, portal vein normal. The pancreas is normal in size and shape, MPD is normal. No ascites, no significant lymphadenopathy.
So what do you make out of this report?
In this, it is looking like a GB mass, sir.
But they have said gallbladder normal.
The mass is in the GB fossa.
So you should say that the report probably is not, one part of the report is not tallying with the other.
Yes, sir.
It is possible that the mass is on the hepatic side. And what they have said, wall thickness normal, is the wall on the peritoneal side. But then the sonologist should have said that clearly, that it is not that the entire gallbladder wall thickness is normal.
Yes, sir.
Isn't it? That
Yes,
is
sir.
the most likely explanation. And if the gallbladder is really normal and there is a mass in the gallbladder fossa, then what would be the diagnosis?
It can be a hilar mass, and also it can be intrahepatic SOL.
What else is missing in this ultrasound report which you would like to know? You said it could be a hilar mass. If it is a hilar mass, what other finding would be there? How do you decide the level of obstruction?
Depends on the dilatation of the extrahepatic biliary system and intrahepatic biliary radicals. If it is in the hilum, the distal part will be collapsed and intrahepatic biliary radical dilatation will be there. And confluence, they have not mentioned in this. Confluence wouldn't have formed if it is a hilar mass, and CBD they have mentioned, which would have been collapsed.
So CBD is dilated, although
Yes.
they haven't mentioned specifically about confluence, but the fact that CBD is dilated means that the obstruction is below.
Where is the normally CBD measured by any radiologist?
Sorry, sir?
What is the site where the CBD is measured by any radiologist as a protocol? Lower CBD, mid CBD, high CBD, hilum?
Lower CBDs.
I think you're wrong. So it is measurement is always where the portal vein crosses the CBD. That is the site where they can measure the CBD, and this usually crosses about the cystated CBD junction. So if the CBD is dilated at that part, which they have mentioned, implies that it is proximal CBD which is dilated, and they are not usually not able to see the distal CBD. And what we are able to appreciate on this is a mass, and with that mass of obstructive jaundice and a dilated CBD. So possibly either the mass is going from the fundus of the gallbladder, and this second part of the gallbladder wall thickness is normal is incorrect statement in this sonography. Or there is a nodal mass. I think they should have, what Dr. Kapoor wanted to know was, is there a nodal mass in the hilum or in the HDL? That is one thing that is important that they have missed.
So a good ultrasound in a patient with obstructive jaundice obviously will show IHBRD, but it should also mention specifically whether the confluence is forming or blocked. And then it should mention the CBD diameter, which, as Dr. Ajay said, is usually the supraduodenal part, because the retroduodenal intrapancreatic part is difficult for the sonologist to see. And then they should also mention at up to what level the common duct is dilated. For example, in Mirizzi, in a GBC neck, in a mid CVD cholangiocarcinoma, there will be IHBRD, confluence will be formed, some proximal common hepatic duct will be seen which will be dilated, but the distal CVD will not be seen. On the other hand, in a periampullary carcinoma, the CBD will be dilated till its lower end. And because it is dilated, it may be seen even in the retroduodenal and the intrapancreatic part. A good sonologist can pick that up. So based on ultrasound alone, you can make a diagnosis. So in a hilar cholangiocarcinoma, you will see IHBRD, confluence is not formed. Mass may or may not be seen. Usually mass is not seen. Only a thickened CBD may be appreciated by the sonologist. If there is bilateral IHBRD, confluence is formed, proximal common hepatic duct is dilated, but beyond that CBD is not seen. As I said earlier, it is either a GBC neck involving the CBD, or it is a mid CVD cholangiocarcinoma, or if there is a large stone sitting at the neck of the gallbladder, it is Mirizzi. If CBD is dilated till lower end, PD is also dilated, both the dilated ducts are approximating each other and almost meeting each other, you don't see a mass in the head of the pancreas, it is periampullary carcinoma. If CBD is dilated till lower end, PD is also dilated, but the two dilated ducts are separate from each other. They don't come close to each other, and you see a mass in the head of the pancreas, then it is carcinoma, head of the pancreas. If you see a mass in the fundus or body of the gallbladder, but still there is IHBRD, CBD dilatation, then most probably it is because of lymph nodes around the CBD in the hepatoduodenal ligament, in the retropancreatic area, which is causing biliary obstruction. So a good ultrasound can virtually give you the diagnosis, the site of lesion. Okay.
Yes.
So here, indirectly, we can infer that because they have said CBD dilated, probably it's a lower end block. And that doesn't fit in with the mass in the GB fossa. Mass in the GB fossa, if it is a gallbladder cancer, it would cause mid CBD or a high block. The other possibility is that this is, as Dr. Ajay said, a fundus or a body mass, which is more on the hepatic side. That is why they have said mass in the GB fossa. And the biliary obstruction is caused by lymph nodes, but then they haven't said no significant lymphadenopathy, although we agree that ultrasound may not have been able to pick them up, especially the retropancreatic nodes. But the fact that MPD is normal rules out head pancreas and rules out one or two types of periampullary carcinoma. So which periampullary carcinoma will have a CBD dilated but MPD normal?
Distal cholangiocarcinoma will have
Yeah.
MPD normal.
So lower end cholangiocarcinoma may have a normal MPD, but a true ampullary carcinoma, a true papillary carcinoma, a peripapillary or a periampullary carcinoma usually will have both the ducts dilated. Okay.
I think it's a semantic, but just correct me if I am wrong. The gallbladder fossa is a term used for a post-cholecystectomy gallbladder fossa. Otherwise, it is the liver adjoining the gallbladder.
Bed, GB bed.
GB bed. It is the fossa means you have removed the gallbladder, then there is a fossa which is left. So it's a semantically wrong term which has been used. Therefore, it is causing a lot of.
Yeah. Okay. What next?
Next, I'll ask for an contrast and CT triple phase of abdomen, sir.
Okay.
So-
let's see.
Sir. This is a non-contrast phase of the CT scan of abdomen.
Sorry, but before you go on to CT, one that you should have asked for a renal function tests at least, if not the other. And if you are going to give a sample for renal function test, you might as well do the entire blood tests at this time. That is one. And second, this I keep saying again and again and again, please get a chest X-ray done before you go on to more invasive and expensive investigations.
Yes, sir.
Always.
Just a small question. Now, why not CA99 at this level? If it is high, it shows the advanced disease.
You want to do
We
tumor
can-
markers now?
Yes, sir. We can get it done. CA99. but it will not give any diagnosis.
So it's a trap question. With the jaundice, I think CA99 has no relevance. So I think I would have been happy if you would have said, sir, because it's jaundice, I would not get, it will not have much relevance. So I would directly get a CT scan done and CA99 once the bilirubin is normal.
Let's see the blood picture first.
Hemoglobin is 11.7 gram per deciliter. Total leukocyte count is 8,000 and platelets are 3.89 lakh. Blood urea is 37, serum creat is 0.9. Electrolytes are normal. Bilirubin, total bilirubin level is 12. Direct bilirubin is 10.7. ALT is 109. AST is 94. Alkaline phosphatase is 255. Albumin is 3.9 and INR is 1.1.
No, rather than reading the numbers, it is better to say that there is no evidence of.
Yes, sir. There is no evidence of any infections, and bilirubin, it is showing an obstructive jaundice picture with a raised enzymes, which is showing biochemical cholangitis like picture without any clinical evidence of cholangitis.
And the nutritional status is reasonably good.
Yes.
Krishna, is this a old case that is being presented because the date is 5th of June 23?
Probably.
No, sir, this is the new case only. I have edited in that old PPT. I forgot to change that, sir. Date.
Okay.
Sorry, sir, for that.
Okay. But see how good examiners can pick up even small points. Yes. So whenever a report is shown or you are showing a report which everybody else can see, there's no need, there's no point in reading out the numbers. We can all read that. It is better to give your interpretation.
Sure.
Yes. Chest X-ray?
Chest X-ray shows no blunting of renal angle. There is no mass or consolidation or any effusion present. It appears essentially normal, sir.
So you were expecting a consolidation?
No, sir.
What do you expect?
Cannonball secondaries or effusion, sir.
So solitary pulmonary lesions or nodules, blunting of the costophrenic angles, mediastinal widening because of lymph nodes. That is what you are looking for.
Okay.
And any lytic lesions in the bones which are seen. Let's see the CT. Show the CA99 level since it is there.
6,180, sir.
So what do you make out of it?
It is very high. CA19 levels more than 1,000 is indicative of malignancies.
Even in presence of jaundice?
Yes, even in jaundice, without cholangitis.
But still, you should qualify your statement that CA99 level in presence of jaundice and especially in presence of cholangitis can be falsely high.
Okay.
And therefore, I would like to look at it once the jaundice has been relieved. That is why, as Dr. Ajay was trying to say, most people would not even get the CA99 level at the time when the patient is jaundiced. They will get it done when the jaundice is relieved by some intervention, and then it will have more value. But I agree that a very high level, although I must caution you that we all have seen very high, even much higher than these levels in benign conditions, including chronic pancreatitis.
This is non-contrast phase of CECT abdomen, axial cuts. Lower lung field shows no effusion. As we go down,
जहां पर आपने एफ्यूजन बोला वो तो अभी एफ्यूजन वाला लेवल ही नहीं था, वो तो मिडिल लंग था.
yes, sir.
एफ्यूजन तो अब यहाँ दिखना शुरू होगा और
Yes.
नीचे.
Lower lung field shows no effusion. As we come down, liver borders appears normal. Biliovascular markings are prominent, and as we go down, there is patchy calcifications in the aorta, walls of the aorta and its branches, and as such, there is no collection in the peritoneal cavity.
Go up, go up, Go to the gallbladder area. Yeah. So even here you can appreciate that GB is distended and you can see a
Yes.
mass, and it is probably an hourglass-like deformity of the gallbladder. You can see this mass in the mid body of the gallbladder, isn't it?
Yes, sir. It can be seen. I want to comment better about this in the other phases, sir.
Yeah, that's okay, but don't miss an obvious finding.
Okay, sir.
You say that it is there, but I would like to comment it or see it better in the contrast enhanced phase.
Okay.
Otherwise, an examiner like I interrupted you, the examiner will interrupt you that you didn't notice this. So don't skip anything. If you see it, you mention it.
You would like to see it in which phase now, arterial or venous phase?
Portal phase, I want to see the mass, sir. Shall I continue?
Yes, yes.
This is the portal phase. Again, lower lung field shows no effusion. As we come down, liver borders appear regular, and in this area, the intrahepatic biliary radicals appears dilated. As we follow this is the left hepatic duct, this is right anterior, and this is right posterior. This is the area of confluence. As we trace down, the confluence we are not able to appreciate. Tracing even lower down, even in the head of the pancreas.
I thought the confluence is forming. Go up again. See the most proximal hepatic duct. Yeah, this one.
This one, sir.
Yes.
This
And follow it up into the right and left, because there is no mass at that area.
yes, sir.
I think confluence.
Once we trace the gallbladder, sir, it is looking like neck of the gallbladder.
Okay, let's show.
Coming to gallbladder, here we can already see a mass,
Enhancing mass.
enhancing mass. The gallbladder, we can visualize, which appears distended. And as we come down, there is a mass at the mid-body level of the gallbladder, which is constricting the gallbladder, dumbbell or hourglass shaped. As we come down,
but at this level, you see this gallbladder neck, you see the cystic duct, you see the common hepatic duct, isn't it?
yes, sir. This,
May I interrupt, sir?
Yeah, Rajendra.
Compare the contrast in the spleen with that in the right lobe of the liver.
yes, sir.
The right liver is lighter than the spleen is.
Yes, sir.
Left lateral segment is very well. It's looking uniform and it's looking okay.
Yes, sir.
So could this be fatty liver? And that mass is a pseudomass.
This mass, sir, it can be a fatty liver, but the mass is involving the GB, causing the constriction, which is very unlikely in fatty liver.
What is the importance of fatty liver in this diagnosis?
Fatty liver tells that the liver is compromised. If we are planning for any major resection, we have to be cautious.
How much FLR you leave in a fatty liver?
It is 30%, sir.
So you should have said this in the first instance. As soon as Dr. Rajendra Desai asked you what is the importance in this patient, the word FLR should have come in the answer. That as compared to a normal liver, you need more FLR in a fatty liver, in a cholestatic liver, in a chemotherapy associated hepatitis, steatohepatitis liver, isn't it? So
Yes.
You should show your knowledge. He should not ask you a counter question to get the answer out.
Okay.
And also, fatty liver is unlikely to be patchy, that right lobe is fatty and left is normal. So what else could be the cause of the difference in enhancement?
Even asymmetric obstruction can produce this picture because biliary obstruction leads to portal hypertension. Biliary obstruction leads to sinusoidal pressure increasing and it leads to portal hypertension. So that the flow in that part of the liver might be reduced because it's not well drained. In those circumstances, it can give an appearance like this. And fatty liver can be segmental, can be subsegmental, can be patchy. You can get a variegated appearance. So what Kapoor sir is trying to get from you is a negative point, that it can still be fatty liver, but so clearly demarcated between left lateral segment and right liver will not be there.
Okay.
And as you can see, the growth is at the confluence of the posterior superior and the anteromedial.
Yes, sir.
So that would mean there is obstruction there.
And we haven't yet discussed, but we will have to look at the portal vein also, the right branch of portal vein.
Yes.
Yeah. Okay. Carry on. So in this cut, I think the neck of the gallbladder and the common hepatic duct, and that probably is the cystic duct at the top, which is joining. If you follow it
Yes.
up and down, maybe you will better appreciate it.
Yes, sir. Here, if we follow, this is looking like lower body, infundibulum, neck part, and cystic duct, sir.
That's what I thought.
If we
Because I don't see anything at the confluence.
confluence, yes, sir. The confluence is not made out in this cut, sir.
No, I'm saying I don't see a mass at the confluence.
Okay, sir.
So
The mass
I
is
think confluence is forming.
okay, sir. But this is the cystic duct and neck part.
Hmm.
Okay, I'll go down, sir.
Yes.
So from here, there is no structures, no CBD is visualized. Lower down.
And in fact, it seems as if the wall of the duct is thickened and enhancing. See the enhancement here at the area where the CBD should have been?
This area, sir.
Yes, yes. If you
There
follow
are
it up,
multiple lymph nodes here.
yes.
The periportal area.
Yeah. In fact, on the left also, probably that hypodense is the lymph node, this one.
Yes, sir. This part.
This is a large lymph node, probably.
Large lymph nodes are there in the periportal area. If we will trace the CBD once, sir, till lower down. As such, we are not able to make out. Here in this one cut, it is appearing like CBD lower down, but not able to appreciate properly.
So the point which Dr. Ajay was telling you, that when the sonologist said CBD 12 mm, it was in the upper part of the
Part. Yes, sir.
CBD.
So coming to the portal vein, right portal vein and left portal vein, it is normal without any involvement, and the portal vein is forming.
How do you say on CT scan that a portal vein is involved? What do you see?
There can be contour irregularities or any sudden obliteration, tapering or obliteration of the portal venous branch.
So it starts from proximity, that if a vessel is close to a tumor, I'm now talking in general.
Okay.
So in some areas, you will see a normal fat plane. For example, a pancreatic head mass and the superior mesenteric or portal vein, you will see a normal fat plane. For example, esophageal mass and aorta, you will see a normal fat plane.
Sir.
So first step is obliteration of the fat plane, that there is no fat. But that can be a false positive in the sense that if the patient is emaciated, suppose there is significant weight loss, there is no fat, so there will be no fat plane. So absence of fat plane does not necessarily indicate involvement. Next is the area or angle of contact, which is more important in case of aorta, with esophagus, in case of SMV, portal vein, in case of head of pancreas, not here so much. So if it is less than 90, it is not involved. If it is 90 to 180, it is suspicious involvement. If it is more than 180, it is most likely it is involved. Next is alteration of the shape. Normally, these veins or these vessels will be round or maybe oval. But if there is a change in the shape, then it suggests involvement. Then irregularity. Normally, the wall, whether it is round or oval, is smooth. If there is irregularity, that again indicates involvement. Change in the lumen. Below the level of tumor, the lumen is this much. above the level of the tumor, the lumen is this much, but in between the lumen is smaller. That again indicates involvement. Then there will be complete obliteration or encasement, and even thrombus in the vessel is an indication of involvement. So these are various terms which are used by radiologists, and they indicate the extent of involvement. Not every term will apply to every case, but especially in esophagus and aorta, and especially in head, pancreas, and SMV portal vein, all these terms are applicable. So now you trace the main show the main portal vein, and then here right is more important, left is not of much importance. So show us the right portal vein, and also because of this differential enhancement, show the right anterior and right posterior sectoral branches of the portal. Go from below upwards, go from normal to abnormal.
Okay.
So start from the formation of portal vein.
This is the portal vein, sir. As we go up, here there is change in the shape, sir.
Yeah, see the shape, it's not rounded, but
Yes,
here you don't have the tumor, the primary tumor, it is the lymph nodes. And now you see all around, you see these hypodense large lesions, they are all lymph nodes. So it is the lymph nodes which are causing the alteration of portal vein, and most probably they are the ones which are also causing the biliary obstruction.
Okay, sir.
And you can see the tumor in the gallbladder very well.
Yes,
hourglass gallbladder and enhancing focal. This is focal thickening of the gallbladder wall, which is highly suspicious or almost diagnostic of gallbladder cancer. But it is in the mid-body.
Mid-body, yes, sir.
Yes.
So here there is change in the shape of the portal vein. As we go up, still there is a compression with the periportal lymph nodes. Here it relatively appears in shape, and the right portal vein we are seeing here.
So that's the right posterior. Where is the right anterior? Where does the right anterior sectoral pedicle lie? The anterior sectoral pedicle lies in the gallbladder fossa. The posterior sectoral pedicle lies in the line of the Rouvray sulcus.
Yes, sir.
So do you see the right anterior sectoral branch of the portal vein? Follow the right portal vein. Do you see dividing it into two?
No, sir.
We don't see right anterior, isn't it? So probably the right anterior
is involved.
Pedicle is involved.
Yes, sir. The mass is here only, and the right posterior is looking normal, and right anterior we are not able to make out.
So since you have seen those large nodes, anything else you would like to see and tell us?
Yes, sir. I want to see aortocaval lymph nodes also.
Yeah. Show the aortocaval area.
As we go down, this is the aortocaval area. This is the IVC, and this is aorta. There is a big mass here also in the aortocaval area. As we trace it, there are multiple lymph nodes here also.
So what is the importance of these nodes?
Aortocaval lymph node involvement signifies it as a metastasis. So the patient will become a metastatic disease and go for palliation rather than surgery.
Yeah, so your answer should be, if I see these large significant nodes in the aortocaval, especially left para-aortic, yahan left para-aortic nahi dikh raha hai, it is all pre-caval and aortocaval. I will get an FNAC from these, and if it is positive, by and large, and at least for the exam, it makes it metastatic or equal to metastatic disease and no surgical resection. Although, if further discussion happens, you have to say that now there are groups which are coming up with the philosophy and practice that even in presence of these nodes, they are going ahead with the resection to see whether it helps. So this is one type of oligometastatic disease, distant nodes and small adjacent, few in number, peritoneal or liver metastasis. I think recently at the IHPBA, Dr. Anil Agarwal probably presented a series of some 30 cases, my colleagues informed me. So we will have to wait and see. But for the exam, at least, you have to say that this indicates metastatic disease. Do we have an arterial phase? Can we see the artery?
Yes, sir. This is the arterial phase.
Just follow the arteries and show us.
Yes, sir. This is the origin of the celiac trunk. First branch from the aorta, and as we trace it above, here it is giving branches. This is the left gastric, this is the splenic artery, and this is common hepatic artery.
और वो बहुत मसल उसल तो होता नहीं है, साइनस खुल जाता है, ब्लीड मारता रहता है।
We'll
उसको तो टीयूआरपी अगर करना है ना,
trace the splenic artery first.
Please mute yourself, everybody. Yes, carry on.
As we trace the splenic artery, it is the inferior border of the pancreas. It has a
Dr. Sara, please mute yourself.
splenic has a tortuous course. As we trace the common hepatic artery here, which is the gastroduodenal artery giving off from common hepatic artery, and then it is continuing as proper hepatic artery. This is the proper hepatic artery, and as it gave off the left hepatic artery here, and this is the right hepatic artery. If we trace this, this is the left hepatic artery, and coming to right hepatic artery, this is the right hepatic artery dividing into right anterior and right posterior.
Yeah, so that's where we should have seen the right anterior sectoral portal vein also in the
Yes,
UV bed.
So there is no arterial anatomy is normal, sir, in this patient, and there is no involvement of major vessels by the tumor.
I would say that the right anterior is just across the tumor.
Probably later on, here this is the normal gallbladder. After that, I'm sure it would be going into the tumor, but that doesn't really matter. But I'm sure it will be involved here.
Next,
So what will you do next?
I want to take a biopsy from the aorta cava lymph node, sir. FNA.
How?
Ultrasound guided, image guided. I'll do it, sir.
Is there a better way?
CT guided will be better than ultrasound guided.
Anything better than even CT?
EUS. We
Yeah.
can.
So if facilities and expertise are available, the best way, the safest way to get a tissue from these nodes is US guided, because once your scope reaches there in the third part of the duodenum, the nodes are lying just behind that, and that is what Dr. Anil Agrawal has been advocating, that that is the best way of getting a tissue from these nodes. If you have the equipment, if you have the expertise, and you can afford, US guided FNAC is the best way, safest way. The chances of complications will be least with US guided FNAC, and if that is positive, as we discussed earlier, at least for the exams, no surgery, but this will be the group of patients where you could say that I will give neoadjuvant treatment and then re-evaluate the patient. Any other investigation before you decide?
Actually, MR we had got it done, sir, to know the confluence.
To us quickly. Anything on the CT report which we did not pick up?
No, sir.
Have picked up?
Sir.
Okay. Yeah. What does the MR show about the confluence?
MR, sir. Here.
Show the cholangiogram.
Here, sir. This is the left anterior. Right anterior and right posterior. In this, the secondary confluence only, it is not forming, sir. And the part we were seeing was this infundibulum and neck part. And this is the left duct. Intrahepatic biliary radical dilatation is there. In the confluence, it is not forming, sir. Secondary confluence is only not. And this is the lower CBD.
Krishna, may I interrupt? The important point is, if the secondary confluence is not forming, and the distal part of the bile duct is free, that's a good thing for you in this condition. Because if you're planning, if the lymph nodes were not there and metastatic lymph nodes were not there, you would have gone for an extended right hepatectomy.
Yes.
So the only thing that would stop you would be a reduced future laminate size, and that you would take care by doing the appropriate maneuvers to make sure that there is FLR hypertrophy.
Yes, sir.
So what are the ways of doing FLR hypertrophy?
One is portal venous embolization of the right portal branch, and
Only right?
and ALPS, sir.
No, only right in portal vein embolization. You don't want to embolize segment 4 branch.
Yes, sir.
In gallbladder cancer, you always have to embolize, otherwise segment 4 will hypertrophy and it will create problems for you.
Yes, sir.
It is always right portal vein and the segment 4 branches of the portal vein.
Yes.
But there is a mid CBD block also.
Yes, sir.
Yes, sir.
That is caused
Because
probably
of the
by the lymph nodes, because the common hepatic duct is dilated and it is in continuation with the left duct. So there are two levels of block. One is caused by the nodes, the mid CBD, and the other is the tumor in the GB bed, the mid body, which is causing the right secondary.
Very aggressive surgeons, if they want to give a lymph node band there, they would probably even do a bit of aspirated duodenectomy. That is mostly done when the lymph nodes are small, not this size.
So the only other investigation I was hinting at it, that if you are planning some definitive neoadjuvant treatment and then reconsideration for surgery, you will probably have to do a PET scan also, because if PET shows extra abdominal disease, then most probably that option will be out. Then you will be going only for definitive palliation, biliary drainage, and then palliative. Okay, I think it's 10. We can close. Thank you. Thank you, Krishna.
Thank you. Thank you, sir.
Thank you, Rajen.
Thank you, sir.